India is now the country hardest hit by the coronavirus pandemic after beating the record this country set for the highest single-day jump in COVID infections. And images like these of crematoriums in New Delhi, overwhelmed with bodies of people who've died of COVID, have put increased pressure on world leaders to help, including the Biden administration, which has partially lifted a ban on the export of vaccine raw materials, ventilators, PPE, and other assistance yesterday.
We do take the very difficult situation that India is going through very, very seriously. You know, the United States and India are the two countries now that have suffered the most. The global pandemic requires a global response. So that's the reason why we and other rich countries have to exert what I think is our moral responsibility to help the rest of the world get this under control.
Two countries led by demagogues, Trump and Modi, whose anti-science beliefs led to the deaths of hundreds of thousands. Here in the U.S., nearly 3 in 10 Americans are fully vaccinated. More than 40% have had at least one dose. But so far, the CDC has reported 8% of people who got one dose of the two-shot Moderna and Pfizer vaccines have missed their second. And in some states, demand for vaccines is falling so low that officials have been asking the federal government to reduce or hold off on shipping new doses altogether. And while demand is still high in this state, where more than half of all adults have gotten at least one dose so far, with relatively few missed second doses, of course, we can't end the pandemic on our own. Joining me to discuss are Dr. Louise Ivers. She's the Executive Director of Mass General Center for Global Health, MGH's Interim Chief of Infectious Diseases, and a professor at Harvard Medical School. And Dr. Bhadelia is an Associate Professor of Infectious Diseases at the BU School of Medicine and the Medical Director of the Special Pathogens Unit at Boston Medical Center. Doctors, it's very good to see you both. Thanks for your time. I appreciate it.
Thank you, Jim.
Dr. Bhadelia, if I can start with you, how bad are things in India?
Well, Jim, we're looking at about 350,000 cases a day and, a couple of thousand deaths. And I can tell you with utter confidence that that is an undercount because, I, like many others, have family in India. And what you're hearing, as well as what you're hearing on the news, is that the testing capacity is overwhelmed. And so people who are getting sick are not getting tested. In fact, many hospitals in hard-hit areas such as Delhi are not even accepting people unless they come in with a positive test for COVID. And so if you're at home and you never got tested for COVID and you died, you don't get counted. And so the estimates are that the current deaths are actually a undercount. And we all know what happens with exponential growth like this. First, you see the cases go up, and then it follows a set of hospitalizations and deaths. And the models currently show that by mid-May, you could be looking at 4,000 or 5,000 deaths a day in India. And so it's devastating.
Dr. Ivers, I think most of us know what the impact is on certain countries in Africa, which were directly importing vaccines from India, which obviously has been put on hold. But does the catastrophe in India mean for the rest of the world?
Well, first, I think it's just a devastation for the whole world, to see what we could have predicted in terms of not having health systems, really even to be able to take care of people who are sick, who require oxygen. It's really just amplifying what that problem is. What we certainly have to be concerned about, in addition to that kind of humanitarian concern, is that we will see continued spread of variants throughout the rest of the globe. I mean, India is, as you mentioned, a big producer of vaccines for the African continent. A lot of hope was being put into Indian vaccine producers to be able to produce the billions of doses of vaccine that we're going to need for the rest of the world. And at the moment, of course, they have to be really focused on trying to scale up production for at home.
But staying with you, Dr. Ivers, I think I read this morning, my numbers may be off by a drop, but not by much. Roughly 82% of the vaccinations that have been administered in the world have been to upper middle income or wealthy nations, fewer than 1% to poorest nations. Are efforts like COVAX, this international effort involved with the WHO, are they making a dent, or is it more intent rather than effect?
Well, they certainly had the right intent, and they are making some impact. But the biggest problem has been that rich countries just hedged their bets. So they made contributions to COVAX, but then they made separate negotiations with pharmaceutical companies even before vaccines had gone into trials and purchased most of the doses. So the US, for example, was predicted to have about 300 million doses in excess of our own needs by July. Now, recognizing that today the White House talked about donating AstraZeneca vaccines to the rest of the world. They didn't say exactly if they're all going to go to India, but that's a lot of excess vaccine to have. And that even included the anticipated vaccination of younger people and children.
You know, Dr. Bhadelia, I know you're both medical doctors, not ethicists, but what sort of obligation does the United States have? What Joe Biden has said, even though he's shown more interest in helping the world the last couple of days, particularly with the problems in India, his position is my first responsibility is to the people of the United States, and then we'll think about helping citizens of the world. What's our ethical responsibility in your estimation?
Well, I think it's the ethical responsibility is very much tied into our own survival. Our destiny is tied with the destiny of the rest of the world as we get out of this pandemic, right? I think that it's great to see the U.S. is immediately providing things, as Dr. Ivers said, the PPE, the ventilators, the other sort of direct impact right now. They've also loosened the export of the raw material that are needed for vaccines, but we need to go further. One of the other things that, the U.S. is being asked to do, as have other rich countries, is to help build vaccine manufacturing capacity and to potentially suspend intellectual property rights so that other countries can start making the mRNA vaccines and others that currently are under these intellectual property rights. I think that's going to help us. That the ethical responsibility is that if we don't see most of the world immunized for a couple of years, which is what we're likely potentially seeing at the rate that we're going right now, you're looking at societies that can't get back to normal. You're looking at hospitals overwhelmed in many parts of the world that keeps them from taking care of other medical problems. You're looking at their healthcare workers getting sick and not being able to provide for the health of the institution. But it's also looking at all of our recovery, as Dr. Ivers said, continued introductions of variants, the fact that the global economy can't get back to normal. And so we are investing in our own survival, aside from the ethical humanitarian imperative.
Dr. Ivers, is any part of that you disagree with?
I just agree with everything and would say even more. I mean, we absolutely have a moral responsibility to participate in the global recovery, and we have plenty of vaccine for ourselves. So we have long gone past the point at which we had to kind of think first of ourselves before we think of others. Absolutely moral, but also a public health imperative to do it as well.
Let's come back to the United States if we can. I mentioned that there were a bunch of states that are turning down doses from the federal government. They include places like Kansas, Mississippi, Iowa, Louisiana. In response to those rejections, for lack of a better expression, by those states, our own governor, Charlie Baker, had this to say late last week.
The simple truth of the matter is we could do 2 or 3 times as many doses here in the Commonwealth on a daily basis as we actually had supply for. And I have expressed on several occasions to the federal government that if they have states that are turning away doses or not accepting doses, we'd be perfectly happy to take them off their hands and make sure that they get used quickly.
Dr. Bhadelia, does anything the governor said trouble you?
Well, I think, Jim, the more people we vaccinate, the better it is. The concern that I have is that I see this pattern forming where you see states like Massachusetts, and New Hampshire, which, by the way, 60% of people in New Hampshire have gotten at least 1 dose. Mississippi, 30%, half as many people have gotten 1 dose. And you're seeing a near future where states like ours, community like Boston, achieves community level immunity. But then you see other states that don't achieve that. And so they continue to have these outbreaks. And similar to the thing that we talked about, the global efforts, I think that we need to work on ensuring that there's vaccine equity in our states. And if that effort requires additional, ground game and trying to get people in Mississippi and Alabama and Tennessee and all those states that have low vaccination rates to accept the vaccine, and that's the hard work that we have to do, because if the virus continues to transmit there, you're going to see the same types of problems that we're talking about with the virus transmitting in other parts of the world.
Dr. Ivers, in addition to the discrepancies from state to state within our borders, I'm sure you've both seen the poll today that in the wake, even after the reauthorization, that's probably the wrong term, but the ending of the pause for Johnson & Johnson, a stunning number, fewer than 1 in 4 people who were not immunized say they would take the Johnson & Johnson vaccine. And while some have said, well, there's enough Moderna and Pfizer, it seems to me as a non-professional that that kind of concern trickles down to those who are hesitant to begin with and causes even more hesitancy. Am I wrong?
I think you're right, but I also think we should expect that at this phase of our own vaccination campaign in the US, that we see a slowing of the pace. All the eager people who were ready to go and wanted to get the vaccine, and now the hard work, the real hard work begins. Public health work is hard. We have to get into the nuances and understand the complexities of why people might be hesitant, why they wanted to delay, if it's really that it's their hesitancy or it's still related to their access. Are we getting into the communities? Are we engaging community leaders? So I think I'm not as concerned as much about the slowing down of the pace as I am just cognizant of the fact this means that we really have to do even more work now. We have to roll up our sleeves even more.
Well, let me say, I have 30 seconds for each of you, if I may. Your optimism, Dr. Ivers, is greater than mine. If we have 30% hesitancy or people who are self-declared Republicans who won't take it, white evangelicals 30%, we're not even hitting on people under 16 years old, not to mention the global situation you both discussed. Explain to me how we get from here to herd immunity, either in the United States, the world's wealthiest nation, or in the rest of the world. Dr. Ivers first, if you can.
Well, we just have to roll up our sleeves, Jim. We can't just be complacent. We have to get into the communities. We have to engage with communities. We have to raise up community leaders and bring them into the conversation. This is kind of grassroots public health work. On the global side, we have to stop hoarding vaccines. We have to suspend the patents. We have to share technology, and we have to contribute to building capacity. And we can get there if we don't lose momentum. I do think some people feel like the pandemic is almost over or it's winding down, and others are still, working on the front line. So we have to stay alert and not be hasty to kind of retreat back into relaxing.
Dr. Bhadelia, you get the last 30 seconds. Make me more optimistic. Go ahead.
I think the cause for optimism is that we have experience with this, with things like the Ebola outbreaks, with the emergency use authorization vaccines that we use there. Here's what the ground game looks like, Jim, is that here on in, it becomes a conversation between people who are in the wait and see category. Those are the people who are most likely to get vaccinated. We need to arm our providers, our physicians, our pharmacists with the information that they need to answer the questions that people have. We need to make it as easy as possible for people to access vaccines. And so things like President Biden asking employers to let people off from work to be able to get vaccines, or allowing vaccines in as many stores and pharmacies as possible, so working adults, which is really the population we're getting into, can access it, but also staying ahead of the misinformation. We have to sit back and listen, figure out, as Dr. Ivers said, what the hesitancy is, and then we need to then combat the disinformation and misinformation with the good information, so we can pull those people who are in the wait and see category into the vaccinated category.
Dr. Bhadelia, before you leave, I was remiss before when you said you had family in India, and I didn't follow up and ask you, are they okay? Are they okay?
I lost 2 of my aunts in the last week. My father lost 2 of his sisters. And you'll hear the story over and over again. There's a lot of Indian Americans who have family in India who've lost family this week.
I'm so sorry to hear. I'm so sorry. Dr. Bhadelia, thank you for your time. Dr. Ivers, thank you for yours as well.